Welcome to the Johns Hopkins Medicine online webinar series. Today, Johns Hopkins Surgeon-in-Chief, Dr. Andrew Cameron, will be speaking about reasons why one should consider organ donation. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenter. The last 30 minutes will be dedicated to our live Q&A session. To submit a question, please type your question into the Q&A box and click send. Your questions will be seen by others watching this presentation, so please note, if you do not want your name attached to your question, please check send anonymously. We will do our best to answer all the questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. Please note this program is being recorded. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And now I would like to welcome Dr. Andrew Cameron to begin our presentation.
Mark, thanks very much. And thanks everybody for joining us this afternoon. My name is Andrew Cameron, and I am a transplant surgeon at Johns Hopkins. I've been doing that for about 20 years. And I'd like to take about 30 minutes of your time to walk you through the complicated and very interesting and very important topic of organ donation. We'll go through the problems that we face, some of the solutions we're working on at Johns Hopkins, and then we'll take the next 30 minutes to go over any questions or issues that you guys might want to raise. So I appreciate your time and your attention to this problem. So what is the problem? Well, this is 2024, and secretly, nobody dies of old age. Nobody just runs out of gas. Happily, it's hard to die at Johns Hopkins. You have to die of one very specific thing. One of your organs runs out, and it pushes us to our limits to help you. It could be your heart. There are 5 million Americans with heart failure. 30 million Americans with lung failure. What I'll talk about today is the 500,000 Americans with kidney failure on dialysis and the 500,000 Americans with end-stage liver disease or cirrhosis. This is the problem at hand. Now, that's the bad news. The good news is there's a solution to end-stage organ disease some of the time, and that is transplantation. So let's imagine you or a loved one has kidney failure. Now, what does that look like? So we talked about 500,000 Americans on dialysis with kidney failure, waiting for a transplant. That wait can be 5 to 10 years long on dialysis. It's a very tough go. Some of you may know that better than I do. What do these people look like on dialysis with renal failure? They tend to have hypertension or diabetes typically. There are 100,000 Americans on a transplant wait list for a kidney transplant. Incredible how many people need a kidney transplant in the U.S. We only do about 20,000 kidney transplants a year in this country. Now, that may seem like a lot. 20,000 is a big number for sure. But compared to 100,000, it's not nearly enough. We do about 250 kidney transplants a year at Johns Hopkins. So that's what, one almost every single day. That's a lot, but not enough. I thought this might be neat. I'll just show you real quickly what a kidney transplant looks like. So if you need a kidney transplant, you come into Hopkins and you get an incision, which we show up here in the corner, on the right lower aspect of your abdomen. And we open you up and we put the new kidney in down there. So you keep your 2 bad kidneys. You end up with 3 kidneys at the end of the transplant, a new one, which works great. And the 2 that you came in with, you actually have 3 kidneys. So how about that new kidney? The new kidney works fantastic. If we track down everybody that had a kidney transplant over the last year, 95% of them, almost everybody, would be alive and well a year later with a functioning kidney transplant. Even more amazing, if you need a kidney transplant and you get one versus you don't get one, the folks that get a kidney transplant get off dialysis for 20 years. They live an average of 13 and a half years longer than somebody who stays on the list without a transplant. So kidney transplants are amazingly successful, amazingly effective in treating end-stage renal disease and getting you off dialysis. Let's talk briefly about end-stage liver failure. All right. Another 500,000 folks not on dialysis, they have cirrhosis of the liver. The things that make you need a liver transplant are excessive alcohol use or what's called NASH. You may have heard that called fatty liver. Now, interestingly, what you don't see on this list for causes of end-stage liver disease is hepatitis C. That used to be the most common cause of end-stage liver disease and liver transplant, but now there are excellent new medicines for hepatitis C, and they cure it almost immediately. It's a bit of another miracle, to tell you the truth. We talked about 100,000 Americans on a wait list for a kidney transplant. There are 20,000 Americans waiting for a liver transplant. We talked about doing 20,000 kidney transplants a year in the United States. We only do about 7,000 livers a year. We do 130 at Hopkins, not 250. And so that's what? That's every other day, every third day. A few times a week, we do a liver transplant at Johns Hopkins. Let's talk about the results. In the kidney transplant, you kept your 2 kidneys and you got a new one. With a liver transplant, we take out your old liver with its cirrhosis, completely get rid of it, put a new one in that same place. So it's a big, complicated operation. The results, again, are fantastic. You see, 90% of people are alive and well a year later. Our 1-year success rate at Johns Hopkins last year was 98%, which is pretty incredible because these are folks that get their liver transplant because they've gotten to the very top of the wait list. And there is a system that scores how sick you are. And you have to get pretty darn sick to finally get a liver transplant. It's a pretty tough game to play, but ultimately very successful if you can get that all-important transplant. All right, so let's get to the issue. This is why we're here today. This is what we're going to talk about for the next 40 minutes. We talked about the problem. We talked about the solution. The solution is very, very effective. In fact, it's a victim of its own success. Organ transplants are so effective that there is a very, very long line to wait for an organ. There's not enough organs to go around, and that's what brings up the all-important topic of organ donation. Let me show you a graph. It's a pretty incredible figure. Start with the blue line at the bottom. It's flat. That's the number of donors we've had each year for the last 20 or 30 years. It's not going anywhere. Look at the yellow line above it, almost going off the screen. That's the number of people on the wait list, like we talked about, over 100,000. And look at the difference between those two lines, which just keeps getting bigger. That difference is the amount of time you have to wait on the organ transplant wait list. As you can see, transplant is a success, but there's not nearly enough organs to go around. Let me show you a couple more numbers. There's not going to be a quiz on this stuff. So I looked at the wait list on Friday when I was getting ready for this talk. Over 100,000 Americans on that UNOS wait list. Here's an even more important number. 20. Remember that number. 20 people die every single day in the United States waiting for an organ transplant that never comes. And that's a problem with organ donation. So we'll talk here for an hour, have a good conversation about organ donation. Somebody will die during that time. Not because they have a disease that we couldn't figure out in 2024, but because there wasn't an organ, which if we had it, we could have easily saved their lives. That's the importance of talking about organ donation. All right. A few more minutes on the organ shortage. Why aren't there enough organs to go around? You know, that it's sort of maybe people assume, oh, everybody knows there's not enough organs. Why is that? Well, there's some math here. We talked about the demand. 100,000 Americans need an organ transplant. Let's talk about the supply. The supply is people that die and agree to donate their organs. So why aren't there enough? There are 300 million people in the United States. 2.5 million people die every year. Now, if we only have 100,000 folks on the wait list, that should be more than enough organs. Unfortunately, the 2.5 million folks that die every year, there's not enough organs. There's only 10,000 donors out of that 2.5 million. Now, what's going on there? Well, the problem is twofold. Number one, in order to die and donate your organs, you have to die in a very specific way. You have to die essentially in an intensive care unit, brain dead from the neck up, and pretty much normal from the neck down so that your organs will work well into the person who gets the transplant. That right there cuts the number down from 2.5 million potential donors to about 30,000 only. The other problem is that of that 30,000, only about a third agree to donation. So now we're starting to get at the problem of why there is an organ shortage. And that is that only a third of the country agrees to donate their organs. If we could change that fact, if we get more people to understand the importance of organ donation, like we're trying to do this afternoon, we could probably get more than a third of the country to agree to donate their organs. And that would start to save those 20 lives that are lost every single day. All right. We got that wait list way over 100,000. Why don't people donate? This is maybe the single most important thing we'll talk about today. What's the problem? If 2/3 of the people say no, why do they say no? If organ donation can save lives and is a wonderful thing to do, why do people say no? Well, it turns out if you go to the DMV, where we ask folks, and you bring folks into a room and you say, hey, you were just asked if you'd be an organ donor and you said no, tell me why you said that. Turns out people often say one of four things, and maybe you can guess what they say. Well, they say, I got to stop. I got to stop. We're talking about why organ donation isn't good enough. Maybe we should be celebrating. Maybe we should say it's a miracle that 100 million people, a third of the people in the United States, agree to organ donation. In our country right now, getting a third of the people, 40% of the people to agree to anything is actually a bit of a miracle. And if you think about it, you're coming to a family on maybe the worst day of their life, and you're asking them to give a gift to help a stranger who is someone they will never meet. It is somebody they don't owe anything to. And you ask that person at their time of trouble, will you help? Perhaps it's a miracle that a third of folks in that position will say, yes, you can have my loved one's organs. Nevertheless, we only have 100 million of those 300 million people in the US that agree to donation. We could do even better if we could convince more people to say yes. Why do the people that say no say no? Well, one problem, maybe, is that we're asking them at the DMV. That is a pretty tough place to ask anybody for anything, because if you've ever been to the DMV, you're been waiting in line all day and you're sort of hot and sweaty, and it's a tough place to ask people to give one more thing. Nevertheless, other public health campaigns in which we've asked people to wear a seatbelt or get cancer screening or don't drink and drive have been successful. And the organ donation campaigns we've tried have not been successful. And again, maybe that's because of where we're asking. Nevertheless, people, if you ask them, why did you just say no, will say no for one of the following four reasons almost always. Number one, if I say yes to organ donation and you put that heart on the back of my license, when I'm taken sick into the hospital, doctors won't work hard to save my life because they want my organs. So that's a tough one. That communicates a profound mistrust of the medical system. And that is going to be somebody who thinks along those lines is going to be very hard to talk out of, because they really don't trust the system. And some people in this city have a very good reason not to trust the system, because maybe they've not always been treated fairly in their life. Another common thing people say when they say no to organ donation is they know what you're going to do with an organ if they donate. You're going to give it to a rich person or a white person or a person who drinks too much or takes drugs, and they don't think it's a good idea the way the system works. They might say, I don't know if I want to donate or not, but I just don't want to talk about it. I'm 16 years old and I'm never going to die, so we don't need to talk about this. Or I'm 70 years old and I'm starting to think about dying, and so I'm really uncomfortable with this topic, and I understand that. The last thing they may say is, my religion doesn't allow for donation. Or maybe they might say, you wouldn't want my organs, I'm not healthy enough. And that gets us into the myths and misconceptions of organ donation. Turns out all the major religions support organ donation. And people who think they're overweight or they have diabetes or I was in a car accident, it turns out often those people can donate an organ, and they certainly can donate tissues too. So those are myths and misconceptions. Now let's talk. So we've gone over the problems of not enough organs to go around and why people say no. Let's start talking about solutions. Let's talk about how we get people to a yes. And I'm going to run you through a couple programs we tried at Johns Hopkins that are attempts to get people to buy into the idea that organ donation is a wonderful, important, life-saving endeavor. All right. So we talked about maybe the problem is where and how we're asking. The DMV isn't a good idea. Let's talk about asking in a different way in a different location. All right. So I'm going to tell you about one thing we tried social media. This is the part of the talk that you could probably take off. Everybody knows what Facebook is. Everybody has a phone. Everybody has apps. So let's talk about Facebook. We ask people if they'll be a donor at the DMV because everybody goes to the DMV. That's a good place to get people. There are 300 million Americans, 200 million of them drive a car. There are 150 million of those Americans on Facebook. So that's a good place to get to people too. There's 1 billion people on Facebook worldwide. So it's a really good place to have a social media education campaign. It is a way it's often used for silly purposes, but it's a way for you to help you understand your friends and family better. Let's see if we can't use that for good. Here's what we did. We tried to use Facebook to increase organ donation rates. Stick with me here. We asked our friends at Facebook if they would allow us, just like you use Facebook to tell people, what kind of music you like or what kind of food you like or where you went to college or if you're married, we asked them to allow folks who use Facebook to specify if they're an organ donor. And we had some friends at Facebook that were nice enough to help us do that. There's Mark Zuckerberg. He was very supportive of this. And it was pretty darn simple. When you specified on Facebook that you were an organ donor, it did two things. It linked you to your official state registry online where you could go and make it official. And it also alerted your friends that you were an organ donor and asked them if they wanted more information or wanted to consider doing the same thing. Let me tell you what happened when Facebook was nice enough to alter that little tweak in their online platform. They didn't advertise it. They didn't make a big fuss out of it. They just allowed you to specify that you were an organ donor. So here's my page. Here's my family. This is from a few years ago. My wife looks exactly the same. This is my page. And you go down here, click on organ donor. It's one of the, so not work, not home, but health and wellness. You go to organ donor and it allows you to register as an organ donor. It offers you a link to learn more, and then it sends you to your state registry. It sends you to this link, and I'm from Maryland. You click on the Maryland link. 2 minutes later, you're as official an organ donor as if you'd done it at the DMV. Couldn't be easier. Free and easy. Took 2 minutes. Then what happens, and this I think is the magic, is you can see this box down here. It posts, Andrew Cameron became an organ donor today. And your friends can click on that and see if they want to do the same thing, thus giving it the sort of viral spread that we want for this very important message. All right, so was that a good idea or not? Did it work or not? Let me take a minute and tell you what happened. We looked at all the 50 state online donor registries after Facebook made this change to see if there was any uptick in donor registration. Here's what happened. We looked for 2 weeks following the day that Facebook made this change, and we ended up getting data from 44 states. The first day after Facebook made this change, donor registration went up 24-fold in the United States. Remember that flat line that we hadn't been able to move for decades. Now we were maybe starting to get somewhere. But online campaigns tend to have a half-life in minutes. When we looked a week later, it was still up 10-fold. And then when we looked 2 weeks later at the end of this period, it was still up 600%. So did we fix the organ shortage crisis? No, but we were making some headway. Here's a heat map of the states, how they responded to the Facebook organ donor initiative. Let me walk you through 3 states and tell you how we did. So Georgia, home of peaches, I guess, it was the state that had the best response to this initiative. The first day that the Facebook tool was available, Online donation in Georgia went up 12,000%. I'm not even sure what that number means. What it mostly means is that donor registration in Georgia was very, very low, 3 people a day before this happened. A week later, it was still 6,000%. And after 2 weeks, it was still up at 500%. Not the next state is my favorite state, Maryland, home of some of my favorite things. There's Johns Hopkins, and there's my favorite football team. The first day we went up 24-fold. A week later, we were still at 12-fold increase. And then after 2 weeks, we were down to 200%. So we were still double what we were doing before the thing started. Pretty good. The worst state, the state that had the worst response of all 50, was Hawaii, interestingly. I'm not sure why that was. Hawaii, home of President Obama. There's his birth certificate, if you're not sure if that's true. The first day, Hawaii only went up 800%. 2 weeks later, they were 1 week later, they were 400%. And then 2 weeks later, they were back down to baseline. So there was an idea that social media could spread this important message, but it probably hadn't fixed the problem. Now, let me walk you through another thing we did, and then we're getting close to having some question time. The next thing we tried was living donation. So one way to get more organs is to have people die after they donate. There is also a possibility to donate before you die. If you have a loved one, for example, that needs a liver or a kidney, you could donate one of your kidneys or a part of their liver. And that has the advantage of being an immediate impact. So if we sign up a bunch of people via Facebook to donate after they die, I hope they live long, happy lives and they don't donate for 20, 30 years or more. But there are people that need an organ transplant today. And if you have a loved one that needs one today, you could consider donating one of yours. Living donation is perhaps the quickest way to solve the organ donation crisis. All right, let's talk about living donation. It's not as easy as I'm making it sound. The problem is if you're on the transplant wait list and maybe you have a loved one that, or a friend that could donate, it's very, very hard for folks that are sick and vulnerable to ask. You can imagine initiating that conversation. Hey, I need one of your organs. Can I have one? That's not something that everybody's going to feel comfortable doing. People on the wait list may be sick. They may be focusing on going to dialysis. They may not feel like they're able to mount, such an effort to ask. They may not know what to ask or how to ask. People may say, well, I guess I'd consider it, but how long will I be out of work? Who will pay for my operation? What happens to me if I have a complication? All of a sudden, that person has no idea what to say, and that's not really their job to know those answers. It's our job. So we wanted to work on helping people get their story out to improve living donation. All right, we went back to our friends for social media, and here's why. We had a program at Johns Hopkins called the Donor Champion. So we agreed that it was too much to ask somebody to go ahead and ask their friends for an organ. Instead, we told them, come back to clinic next week, not necessarily with a donor, but with somebody who cares about you, an advocate, a donor champion. This champion was going to be the person to ask your friends and family if they would be willing to donate. And that champion was going to get the education they needed to know the answers to the important questions. With this donor champion program at Hopkins, people that had a champion had a 4-fold higher likelihood of getting a transplant than people who didn't have a champion. Pretty cool. The problem was it was labor intensive. Not everybody that had needed, just like it's hard to get a donor, some people didn't have a champion either. And the champion had to come in for educational sessions. It was, a lot to ask. So we decided to make it easy. And we went back to our friends at Facebook and we developed an app. So instead of having a champion running around getting your story out to your friends and family who might be willing to donate, we were going to have an app that helped you tell your story. And we called that app Donor. And you can see the icon here. Everybody has a phone. Everybody knows about apps. Here's what happens when you click the donor icon app. Donor comes up and it takes you through creation of a post. Who are you? What's your story? What's your disease? Tell us what it's like to be on dialysis. Tell people that you need a kidney transplant. You're on the kidney transplant wait list. Go ahead and add a photo or maybe even a video. Post. Not labor intensive. It's free. It takes 2 minutes. People use apps all the time. How did that work? Here's a picture of me telling a group of folks that are on the kidney transplant wait list. They've been on the list for 2 years. They have no living donors, at least nobody they feel comfortable talking to. We brought folks in. We helped them download the app, maybe even create a post. People then drove home, and there were people that had 8 of their friends on the way home say, I didn't know this about you. I'd be willing to donate, to learn more, to donate one of my kidneys to you, for example. People that used the app were 6 or 7 times more likely to have a donor come forward than a similar group of patients that didn't use the app. This is a little more about the app. It seemed like a good idea. We spread it to a whole bunch of different centers. It's not just a Johns Hopkins thing. People created really beautiful stories that told who they were, that when people saw those stories on Facebook, they were sort of motivated to learn more about living donation. It was pretty wonderful. We had a bank of stories. So some people would go look at these compelling stories, and maybe they barely knew the person. That's kind of how Facebook works. Or they could even have been a complete stranger, and they saw the story and they said, this is incredible. This person needs help. I'd be willing to help. That's going to get me into one of my last topics, which is non-directed donors. All right, let's talk about that. When you go into the Red Cross to donate a unit of blood, you don't actually know somebody that needs a unit of blood. You just know that there is need out there, and there might be somebody who's sick and in trouble and is going to need a unit of blood, and you're willing to give. You're giving a donation, but it's not directed. You trust that the Red Cross is going to give it to the person who needs it. All right. Well, we talked about the organ shortage crisis. There's that 100,000 number. There's that terrible gap. We talked about the fact that you could get organs from people that have died and donate. We need to work on that. We talked about how you could have a living donor. We need to get stories out to encourage living donation. There's another option, which is a little bit outside the box, non-directed living donation. So this is the idea that somebody would come forward to Johns Hopkins and say, I heard that organ donation saves lives. I've heard that you can donate before you die, living donation. I don't know anybody on the transplant wait list, but I'd be willing to give one of my kidneys or part of my liver to a stranger to save their life. Non-directed living donation. So it's interesting. If we look at kidney transplants in the United States over the last, say, 10 years, I've shown you here living donation, directed donation, somebody in my family needs one, is actually flat in the United States. That number is not going up. Non-directed donation, people coming forward to donate to a stranger, is the most rapidly growing type of donation in the United States. Turns out there's a lot of people interested in doing that, which is actually really exciting. Let me tell you why. The math. We look at the potential pool of deceased donors. We talked about how 2.5 million people die every year, but we only get 30,000 of them that are likely to be organ donors. So that's not going to be enough donors, especially if only a third of them are willing to donate. We talked about living donation. If you need a living donor, there might only be 1 or 2 people in your family and friends circle that are potentially able and willing to donate. Non-directed donors could be any healthy person in the United States. So there was a poll, are you willing to donate an organ to a family member in need? 86% of people said they would be willing to donate to a family member. What would you be willing to donate to a close friend? 75% of the US said yes to that. Would you be willing to donate to a stranger? Amazingly, 45% of the US said, I would be willing to do that. So if we look at the math with 300 million people in the United States, and we look at only the healthy people who could donate, and then we take 45% of that, you're talking about millions and millions of people that could be a non-directed donor. It's a possible solution to the organ shortage crisis. Guys, we're at 12:30. I want to talk about one more possible solution to the organ shortage crisis. It's a really interesting one, and then we'll open it up to questions. All right, so we talked about deceased donation. We talked about living donation. We talked about non-directed donation. I want to tell you about one more possible solution to the organ shortage crisis, and that's potentially using animal organs for transplants. Okay? An unusual idea. It's an idea that would have obvious advantages. If animals could be used successfully, that would be an unlimited supply of organs. We could have farms of animals that could be used for organ donation. Those animals would be essentially living donors, and that's advantageous, like we talked about. Those animals could be kept very clean and healthy. which could be better than the organs we use now. And most importantly, animal organs can be genetically modified to make them really good for transplant. Now, there's some disadvantages. Depending on which animal you're going to use, they are immunologically different from humans, obviously, in a way that would make them more likely to get rejected. It's not obvious that a pig heart or a pig kidney would work as well as a human heart. There might be some infectious risks that would be specific to pigs, for example, and some people might not be okay with the use of animal organs. We could talk about that too. So if this sounds a bit outside the box, it's been done. You may or may not remember, this is Leonard Bailey, who in 1984, he's a pediatric heart surgeon. There are all the wonderful lives of the kids he saved. In 1984, Leonard Bailey in Southern California transplanted a baboon heart into baby Faye. And maybe that rings a bell. Paul Simon wrote a song about it. Baby Faye, unfortunately, only lived for 17 days. In the 80s, they really hadn't figured out whether animal transplants would work or not. And that baboon hadn't been modified in any way. It was just sort of a regular baboon. It turns out that there's been scientific discovery, specifically in the 2000s, this interesting discovery, CRISPR-Cas, in which you can now very efficiently and easily modify the genome. It's all well explained in this terrific book, Codebreaker. This is Jennifer Doudna, the scientist in California who figured it out. You can easily modify genomes. It's very controversial about whether you should modify human genomes. It's not that controversial that we could easily modify pig genomes and make pigs that are particularly appropriate for organ transplant as donors. There's a company we collaborate called Revivicor, and they have pigs that have 10 genetic modifications. They have 4 genes knocked out to make them less pig-like, and they have 6 genes added in, human genes, to make them more human-like. Those pigs can serve as organ donors for organ transplant potential. Maybe you've heard about it in the news. Just down the road at the University of Maryland, this patient, Mr. Bennett, needed a heart transplant and couldn't get one. There wasn't a heart for him. He got a pig transplant instead from one of these pigs that had 10 genetic modifications. And unfortunately, Mr. Bennett only lived 2 months. He ended up having a viral infection that took his life. But for a month and a half, his new pig heart worked very, very well. Is that good enough? No, not nearly. But is it a potential window to look through and see that one day we might be able to use pig organs? Definitely. We're looking into this at Johns Hopkins. There's a scientist, Kaj Yamada, shown here, who's been working on it for 30 years, who can transplant one of these modified pig organs into a baboon, very similar to humans, and have them live indefinitely with a kidney transplant. All right, we're about ready to quit here, and I'm ready for your questions. There are obviously important ethical issues surrounding the use of animal organs, or do we completely understand the infectious issues we're going up against? We've just gotten through COVID, which was an infection that came from an animal to a human. We don't want COVID 2.0. The government is going to look very carefully at this issue before they let us do xenotransplantation. The other thing I would say is just because we can do something doesn't necessarily mean we should do something. It's sort of the ethics of what we're doing. If my daughter needed a kidney transplant, would I want her to have a pig, or would I want her to have a living donor, or would I want her to wait for a deceased donor? These are the ethical questions we have to consider as we figure out how to make xenotransplantation work. Guys, we've done it. In just a half an hour, we've covered the whole spectrum of organ donation. And I think we've covered some very important ground. If I had to leave you with one message, organ transplantation is very, very successful in saving lives. It's so successful that it's a victim of its own success, and there are long lines to wait for an organ transplant. There's a terrible organ shortage in the United States. It's shown by this graph. The number of people that need a transplant is going through the roof. The number of organs we have available is flat. We talked about possible solutions to this terrible crisis: improving deceased donation, improving living donation, maybe even considering non-directed donors, maybe even considering animal organs. It's not clear which way is the best way to go forward. I'm more than happy to hear your input, hear your questions. The number we have to remember is this: 20. 20 people are going to die today if we don't figure out a better solution. So we need to all work hard on that. Thanks a lot for your time, and I'll be more than happy to hear any questions you might have. All right. I'm seeing questions in the chat, and you guys can tell me if I'm reading these correctly. But the first one I see says, can you please repeat the requirements to be able to donate an organ? Did I hear the donor must be brain dead? And the simple answer to that is there's two ways that we get donated organs. One is from somebody who is deceased. They are brain dead. They have died and agreed to donate their organs, or their family has after they're gone. Yes, that patient must be brain dead. We don't take organs from people that are not brain dead. And that gets back to that concern that people have that if I'm not dead yet, doctors may not work hard to save my life. We don't want any confusion on that topic. You have to be brain dead to donate your organs. There's a whole nother way to donate your organs, obviously, when you're still alive. And that would be living donation. And that would be an example like me giving my kidney to my daughter who needs one, or to a friend at work, or to a relative. So there's two ways to donate your organs. Deceased donation, yes, you have to be brain dead, or living donation. And obviously, we only take healthy people for living donation. We also talked about non-directed donation, which is living donation, but you give it to a stranger, somebody you don't even know, not a family member. All right. Next question I see is there a difference between organ donation for human use or research? That's an excellent question. So people know that when they die, they can donate their body to science. And there are scenarios in which it may be appropriate to have them donate their organs. And we love that. That saves lives. That's a lot of what we've been talking about. There is another scenario in which they may die and they're not, unfortunately, not appropriate to donate their organs. They may have died of a metastatic cancer. They may have died of an infection. It's something that we wouldn't want to transmit to the recipient of that transplant. Those people cannot donate their organs, but they can still give. And that's a lot of what we're talking about today is giving, sharing. And you can share in different ways other than organ donation. As is referenced here, you can give your body for research. And doctors can learn by studying your body short of donation. That's a very valuable thing to do too. Okay, guys, I'm going to keep moving on. These are some excellent questions. I really appreciate them. I'll keep moving on here. Question number 3 says, my uncle is currently in critical care with a MELD score of approximately 35 due to alcoholic cirrhosis. Johns Hopkins requires 2 things to happen: coherency to walk on a walker. He's 5'6". He weighs 125. He doesn't have strength to walk. What do you recommend we do? Okay, so this is a great question too. This is real life we're talking about here. This is a real patient, and we want to help everybody we possibly can. So this patient has been told, it sounds like, by its doctors, we need 2 things to happen to make you a reasonable candidate for transplant. And that may sound like, well, let's not put obstacles in the way. Let's get this done. And believe me, at Johns Hopkins, we want to transplant every single person that has a chance of doing well. Every single person. And we have some innovative programs to do that. Now, I think what we're referencing here is that we need you to have a chance. We know, unfortunately, through making mistakes in the past, that if you haven't been out of bed in 6 months, a liver transplant isn't going to save your life. It'll fix your liver, but there's a lot of other things that are wrong with you that won't get better with a new liver transplant. So we need to transplant people with these very limited resources that have a chance of success. And so we need you to be well enough to get through a transplant. In other words, there are folks that will die without a transplant, but there are also folks that will die with a transplant. And we don't want that. We want to transplant folks that will live with a transplant. And so you have to be able to get up and move around enough to recover from your transplant. I think the coherency thing is you have to say you understand what you're getting into. Now, sometimes folks are so sick from end-stage organ failure, specifically liver failure, that they're incoherent. They have hepatic encephalopathy and they can't participate in a discussion. Sometimes in those scenarios, we allow the family to say, we'll speak for him. He'll take good care of this transplant. He'll agree to take his medicines afterwards. He'll agree to come to clinic if he's sick. He'll agree not to drink alcohol anymore. And that's a scenario in which we would probably rather hear those things from the patient themselves. It's not always possible. It's a challenge, isn't it? You have to get there's not enough organ to go around. You have to get so sick to get to the top of the list that it's a very narrow window to get your transplant and still be okay versus getting too sick to have a transplant. It's very, very difficult. And I'm very appreciative of this loved one who's trying to go to bat for their sick relative. All right, these are great questions. The next one says, if we want to help raise awareness, is there a link or national donation registry that we can share broadly? Not state specific. Excellent question, and I really appreciate that, because isn't that what we've been talking about? You have to get the message out. If you get the message out, people will tend to do the right thing. The answer to your question is yes, Donate Life America. Organization that is responsible for promotion of organ donation. I've served on their board for a while. They do wonderful good work. They do public health campaigns and awareness ads. Donate Life America. Now, state specific, there is a Donate Life Maryland, a Donate Life Pennsylvania, a Donate Life New York. There's one in every state. So there is specifically a state branch of Donate Life America. And then there's the broad organization, Donate Life America, which is not state specific. It's an excellent question. And I think getting involved with them is a great idea. All right, I got another question here. Doing great. This question asks, are genetic family members more likely to be compatible donors than non-related donors? Excellent question. The short answer is probably yes, but it doesn't matter. And what I mean by that is, if you are genetically related recipient and donor, brother, sister, parent, child, you are for sure genetically related enough that it's probably a little better. You probably will have less rejection and need a little bit less medicine because you're genetically related, and that's good. But let's say there was another living donor who wasn't genetically related, a friend. That person's organ, kidney, for example, would still be better than no kidney at all, or even a deceased kidney. So let's imagine there is a deceased donor that is kind of genetically related to the recipient, or a living donor that has no genetic relation. Turns out the living donor kidney's better. And it's better because it doesn't go through the brain death process. So I really like the question. The genetic relationship is kind of helpful, but it shouldn't stand in the way. If you want to be a living donor and you're not genetically related, that's still a wonderful thing to do. And it's still very valuable. All right, question number 6. Is there any testing I have to go through to become a donor? Excellent question. I probably should have spent some time on that. Yes, by all means. We want to look out for the recipients. We want to get them the life-saving organ transplants they need. That's high priority. But an even higher priority is the safety of a potential donor. We wouldn't want to put anybody at risk by donation. And so the answer is yes, there is testing. Now, first of all, you have to literally be compatible. And what that means, it tends to mean blood type. So there's 4 blood types out there. You may or may not know your blood type. O is the most common. A is the next most common. Then B, that's what I am, that's uncommon. Then AB, that's the least common, very rare. You have to be blood type compatible. You know, if my daughter's a B, I got to be a B or an O. You know, if my daughter's an A, I have to be an A or an O. You get the idea. So there's blood type testing just to make sure you're compatible. And then we have to look at you and say, are your organs that you would donate good? You know, do you have normal kidneys? Do you have a normal liver? So if you're compatible and your organs look good, then we would ask probably the most important question, are you safe to donate? And you would have to go through some testing there too. Is my heart okay? Are my lungs okay? Can I get through the anesthesia and the donation operation and get better? If the answer to all those questions are good, and you want to do it, then you can be a living donor. You don't have to worry about all this stuff. If you're interested in being considered to be a living donor, I would ask you to call Johns Hopkins or the Transplant Center where your recipient is listed at. If you don't know anybody, call Hopkins, be a non-directed donor. They will work all this out. You don't have to do all this math. And I don't want you to rule yourself out. Oh, well, I take a heart medicine. I probably wouldn't be okay. Let us decide that. All right. Next question. Is animal transplant only available in certain states or hospital? What other animal transplants are being researched? Excellent question. One of my favorite topics right now. Short answer is very new. Yes, people have been working on it for 30 or 40 years. Only with these new genetic edits I described is it realistic. So there have been a grand total of 4 animal organ transplants anywhere in the world. Now we're from Baltimore, some of us. 2 of them were done here in Baltimore. The University of Maryland transplanted the guy I showed you, and even another guy with a pig heart. So there've been 2 pig heart transplants, and there've been 2 pig kidney transplants, one of which was done in Massachusetts, and the other which was done in New York City. So the answer to the question is yes, it's only being done in a very, very few hospitals. Johns Hopkins is going to be one of them within the next year. And if you're interested in learning more about being a candidate for a xenotransplant at Johns Hopkins, we'd be more than happy to hear from you. Go ahead and send an email to the email that's listed on the screen, and I'll help sort that out. Very interesting. So I'm falling behind here. Next question is, if a family is willing to become donors, does that affect the likelihood that Johns Hopkins would be willing to perform a living transplant on someone that was already rejected? Boy, that's a good question. So if I'm understanding this question correctly, there might be somebody that got rejected for their transplant candidacy. And we could imagine reasons why. They're not safe to get through a transplant. Their heart wasn't good enough. Maybe they have a cancer that makes them ineligible for transplant, but and there are not enough organs to go around. But all of a sudden, there's a living donor that comes forward and says, "Hey, you can have, that's my brother. I don't care if it's a low likelihood of success. I want to donate." That's a tough one. And the answer is, if we don't think we can get you through the transplant safely, we can't take a living donor either. It wouldn't be fair to the living donor. It wouldn't be fair to the recipient. I think the best example with living donation is if there's somebody that got a yes for transplant, but they're just very, very low on the list. They have a low MELD score if it's a liver, or they're going to have to wait 5 or 10 years if it's a kidney. That person gets to go to the top of the list if it's a living donor that's a loved one for them. That's the best use of living donation, not giving it to somebody that really can't have a transplant no matter what. It's a very good question. All right, we got another tough one here, guys. The next question says, my brother is now in critical condition in Virginia. We're trying to put him on a list. If he's accepted in Maryland at Johns Hopkins, hopefully after evaluation, would he be at the bottom of the list in Maryland because he lives in another state? Excellent question. The answer is no. For liver, for example, your place on the list is dependent on how sick you are, not how long you've been on the list and not where you're from. So if you're very sick, you go to the top of the list. Doesn't matter where you're from, doesn't matter if you've been on the list for 1 day. And the tough side of that coin is that if you have a low score, even if you've been on the list for 10 years, you still have to wait. So to answer the question, it doesn't matter the state you're from, and it doesn't matter how long you've been on the list. If you're sick, you go to the top of the list for liver transplant. Excellent question. All right, next one. My son has ulcerative colitis and primary sclerosing cholangitis. He's been receiving Entyvio infusion, which has improved his labs to within normal limits. His liver numbers are near normal, but high, which is expected. He's living a healthy, uncompromised life with little to no issues with his disease process. His scans show this is virtually non-existent in his colon and liver. He's been told he'll need a liver transplant in the future. When do you suggest he has his transplant? When do we have this discussion with the transplant program? Excellent question. PSC and UC are tough ones. We sometimes have people that get a transplant with a PSC with normal lab tests. And there are different reasons for that. One of which is, and you probably already know this, primary sclerosing cholangitis can put you at risk for liver cancer, cholangiocarcinoma. And so sometimes it's a good idea to have a transplant to get that old liver out of there so that you never get cancer. Now, your end of your question is spot on. You need to have a careful discussion with your transplant program. You need to have a hepatologist or a liver doctor that has been following you for a long time and can help you say, even though you're doing well, it's time for a liver transplant. Now, people with how would somebody with normal lab tests ever get a liver transplant? Almost always through living donation for PSC. We talked about liver and kidney transplant at Johns Hopkins. We do somewhere between 50 and 100 kidney living donor transplants, and we do probably 30 living donor liver transplants at Johns Hopkins, which is one of the biggest programs in the country. So living donation is an excellent option. It's almost the only option for a person like you described who has normal lab tests, and happily we do a lot of them at Hopkins. Okay, it looks like we're getting down there. Next question is, can a person with HIV undetectable with AB blood become a donor? What a great question. What a great question. If you had asked me this question 5 years ago, 10 years ago, the answer would have been no. People with HIV couldn't donate. And that was an outdated law based on stigma, not science. There used to be a rule that gay men couldn't donate blood. It made no sense. We got that law changed. President Obama, who I showed his picture earlier, with on the strength of Johns Hopkins research, which showed that donation with HIV positive could be safe, changed the law. Now, a person who's HIV positive can donate an organ. It goes into a recipient that's also HIV positive. Did the first HIV positive to recipient positive liver transplant in the United States at Johns Hopkins. I did that transplant. The person's doing great. So HIV is a pretty amazing disease. It's one that's a chronic condition, very treatable in the United States. And you live so long with HIV that you may need a transplant for some other reason. You can use an HIV positive donor in some scenarios there. AB blood type is okay too. So the answer to your question is yes. A person with HIV undetectable AB blood type can be a donor. And that's work that was done at Johns Hopkins. It's pretty spectacular. Can people with alcohol-induced cirrhosis get transplants in all 50 states or only in Maryland? Great question. We're getting towards the end here, but I think we can handle this one too. Answer is yes, all 50 states. Let me give a little more background on that. There's a rule in the United States that if you need a liver transplant because of alcohol use, you have to stop drinking for 6 months before you can have a transplant. That's a funny rule. That's a rule that everybody agreed on, but there's not a lot of good science. It's not obvious that the amount of time you stop drinking before your transplant determines how well you're going to do after your transplant. So we had a pilot program at Johns Hopkins in which we very carefully selected patients that didn't have 6 months wait period, but still seemed like a good candidate. Those patients did very, very well after liver transplant. In fact, they had the same outcomes as patients that did have the 6 month period. So to answer your question, for alcohol-induced cirrhosis with 6 months wait time, all transplant centers agree that's okay. A transplant without 6 months wait time is something that we've done more at Johns Hopkins than any other program in the world, and we've had very good results with it. So much so that almost all programs in the United States are starting to do it too. Not all of them do as many as we do, but it's an option. So the short answer to your question is yes, all 50 states you can get a transplant for alcohol-induced cirrhosis. All right, we got 2 more questions, guys. I got to keep moving. Can you explain to me a contraindication if you want to see patients well enough to undergo the operation or consider to be put on the list? Wouldn't that contradict with getting too sick to get the transplant? Excellent question. Let's call it a window. Okay, you have to be sick enough to need a transplant. Because there aren't enough transplants to go around, you have to get to the top of the list and be very sick. And yet you have to be well enough to get through the transplant. So sick enough, but not too sick. That might be a narrow window. You're not sick enough yet. Okay, now you're too sick. I hate to say it, but there's like a sweet spot in the middle where you're sick enough to need one, sick enough to get one at the top of the list, but not too sick to get through it. That is a terrible game to play. A patient could easily miss on either end. And that's because there's not enough organs to go around. Imagine a future in which we had enough organs and you wouldn't have to wait until you were at death's door to get a transplant. That's the future we want. And that would only be via better donation or via animal organs. All right, I think we got one more question, guys, then we got to quit. We're almost there. We got a minute or two. Last question says, I am part of a minority group, Asian Americans, which has one of the lowest organ donation rates and also has higher rates for certain illnesses, which could be addressed by a transplant. Are there any specific efforts to increase organ donations in certain groups? What a great question. What a great question. Answer is yes. So we want more donation. We want more donation from everybody. And the person who asked this question knows what they're talking about. Because there are some groups that donate less often. And we need to study and learn about that because some of those groups, and this person makes the point, are highly represented on the wait list. So I don't want this conversation to be about taking. I'm here to take your organs. I want this conversation to be about giving. If you're sick or your loved one is sick, I want there to be an organ for that person. I want your loved one to be able to get a life-saving transplant. If you're in a certain minority group and one of your friends or relatives needs a transplant, I want them to be able to get the life-saving transplant. And to do that, we have to increase donation rates, yes, in groups that tend to donate less often. We need to study that and figure that out. It's an excellent question. It's a good one to quit on. Guys, I want to thank you all for spending an hour talking about a topic which is very, very, very important. It's one that takes a lot of lives in the United States. It's one that if we all talk together and work on together, we can beat. Because all we have to do is we have to communicate better and we have to share better. And people in the US are actually really good at that. So again, I'll thank everyone for joining. I encourage you to call the phone number listed 410-614-5700 with any follow-up questions. Those questions will probably get sent right to me and I'd be more than happy to continue this very conversation. I really appreciate your attention and questions today. And I want to say thank you for spending time with us at Johns Hopkins. Thanks a lot.